Well, good evening. I'll be talking about stable mid-level technology is the way to go. How do you move it? From here?
Just a minute. It is from there.
All right. Thank you. So are there any FIFA lovers here? Yes, then I'd just like to ask you a question. Do you think League 1 or 2 are anyway less than the Premier League? So I don't really think so, and I don't really think that mid-level technology is anyway less than advanced technology. Let's just have a look at the word scenario. Nearly 70% of the world is still living under the tag of developing nations. And all these developing nations have to carry the burden of public health infrastructure, and everybody having an access to advanced technology at all times is not possible. Also, we have to consider when and why to procure new technology. It's not always that the previous technology has become redundant, as the previous speaker spoke. It definitely makes us better clinicians, it improves the care, it makes our practice better, but it has to make financial sense, as we have been listening to it since morning. So finance is definitely big, but does it address the major issues in your practice? So if you look at this Lean Six Sigma technique, which was studied for outpatients in ophthalmology clinics, it showed that scheduling, staffing, patient education, and clinical processes, they formed the first prime 4 major hurdles. So it's the soft skills that actually make more difference than just adding on tech. You have good fancy equipment and your staff is rude, no patient is going to turn on your door. Then quality and efficiency are also not directly proportional. Put up in American Academy, shown by Dr. Joseph Caprioli, that even in the best of the centers in the US, quality and efficiency, they don't run hand in hand. How fast can you keep up with the change? That depends upon the setup you're working in. Where the solo practitioners can keep up with the change as fast as a group practice or as an institution. Laws are different for public sector as well as private sector. In public sector, I work in a medical college, and we have to buy everything through GEM portal, and there are a zillion formalities. Even if I want to keep pace with the best of the best centers, it is going to take me time, and by the time my whole process is through, a new tech is on the corner. The choices and investments in healthcare, you have to now think to add or not to add, because it's basically driven by cost-benefit criteria. Of course, we don't want to compromise on the standard of care, but adding new tech does not mean that all your standard of care criteria would be met. Plus, we have to think the patient's perspective also in mind. Are all the patients having access to insurance? And most of the times in India, there's no concept of co-payment. Now, I'll talk in the language that I best understand, that's the language of glaucoma, because I'm a glaucoma practitioner. So when it comes to diagnostics, all that glitters is not gold. I understand it was time that we moved from shiots to ablanation, but it's not time for everybody to jump on to a ORA or a DCT, because GAT has stood the test of time, it is reproducible in all scenarios, and therefore there's no need to change from a GAT to a DCT for everybody. The technologies are expensive and not interchangeable. Again, I will apply the concept of Lean Six Sigma. We need to have a Humphrey perimeter, but it's not essential for me to have an edge perimeter or a compass perimetry. The same applies to ancillary testing in glaucoma as well. Is it absolutely needed? I mean, most of the times you will be just wondering, should I buy it, should I buy it not? It's not like finding a nice partner for yourself. It also applies for choices for surgery and implants. EDOF lenses do well. Mid-level technology, I have yet to find somebody who is absolutely happy with an accommodative IOL. So mid-level technologies, you buy something when the absolute soda effect has fizzled out, when the technology has stood the test of time, it has been proven to be efficacious in at least an intermediate course of time. When you see that it's working well, having efficacy and safety, then go and buy it. And then, of course, you can provide the best service.
Very nice.
Thank you.
Too good.
Very nice. So we have Dr. Natarajan. You can't sleep. You are in LDP program.
I'm not
He's
sleeping.
literally sleeping. We can't always provide dance floors for him. Okay, so you have to, in very 1 or 2 lines, you have to tell that constantly upgrading to cutting edge technology is essential. Why? Just 2 lines.
Yeah, so I think constantly upgrading no, constantly upgrading essentially is important. As he said, change is a constant thing. So I think, and then you also have the first advantage,
Yes.
first mover advantage,
Yes.
and second, you also definitely do the good to the patient.
Yes, absolutely. Very, very well said. Dr. Jignesh, 2 lines only
Yeah.
for you.
Cost benefit ratio is very important, as she rightly said. If you cover that, 90% of your patient are well satisfied, and whatever the upgradations are there is is not very essential, as rightly put up by Parul. So she has already covered majority of the
Yes,
points.
yes.
So I would rest my case saying that of course mid-level technology is sufficient for 90% of the patient who are satisfied very well. That's it.
Thank you. Thank you very much. Very crisply said.